Recording. Okay, good morning. It is 8:01. Thanks for coming to Regional Trauma Conference. Our presenter for today is going to be Dr. Anna Wu, who's going to be presenting pre-hospital use of TXA to the community. Dr. Wu?
Tom, give me a chance to introduce her.
I just did, sir.
Okay. You just introduced her?
Dr. Wu, can you share your slides?
Yep, give me 1 second. I
Okay.
will pull it up now. Okay, can you see that okay?
Yes, I can.
Perfect. Okay. Well, good morning, everyone, and thanks for joining us. My name is Anna Wu. I'm one of the acute care surgeons at Albany Medical Center, and I'm honored to give this talk for the Regional Trauma Conference today. I will be presenting on pre-hospital use of tranexamic acid, pros, cons, and thoughts from a trauma surgeon. I have no conflicts of interest. So TXA is a huge topic with too much to be able to fully discuss in the space of 1 hour. Excuse me, but I will try to encapsulate the major points over the course of this talk. We'll start with what TXA is, as well as the history of its use in medicine. And we'll go over the biochemical rationale for its use, as well as some of its major complications. The literature on TXA use in trauma predominantly relates to 2 major indications. The first papers, notably the CRASH-2 trial and the MATTERS trial, examined TXA use for hemorrhage control before a subgroup analysis of the CRASH-2 trial was performed to examine TXA benefit in traumatic brain injury, which has been a particular focus of investigation over the last 5 years. We will review the literature on pre-hospital TXA use, both for hemorrhage control as well as for traumatic brain injury, before reviewing current guidelines and drawing conclusions based on the evidence. So without further ado, let's start with what is TXA? So TXA is a fibrinolysis inhibitor. As we know, trauma coagulopathy is a common and very serious problem and can pose a particular challenge for patients with ongoing hemorrhagic shock. If you can't clot, you keep bleeding. If you keep bleeding, you die. TXA is a synthetic molecule that acts as a reversible competitive inhibitor of plasminogen and prevents it from turning into its activated form, plasmin, which degrades clots, as this diagram below shows. TXA is renally excreted, so needs to be used carefully in patients with chronic kidney disease. Its main adverse effects are venous and arterial thromboembolism and seizures, though it can also cause vasospasm, nausea, vomiting, diarrhea, and changes in color vision. TXA can also actually cause hypotension if it's given too rapidly as an IV infusion. Contraindications to TXA use currently include subarachnoid hemorrhage, TXA hypersensitivity, and thrombosis. The Canadian indications also include hematuria and disturbances of color vision as contraindications. TXA was first discovered in the 1960s by Shosuke and Utako Okamoto in Japan, a husband and wife team who were trying to reduce mortality from postpartum hemorrhage at a time when blood transfusions were a scarce medical resource. One of the first uses for TXA was in hereditary bleeding disorders, such as hemophilia, and to control major bleeding from epistaxis. There have been multiple landmark trials in the TXA literature, most notably the CRASH-2 trial, which we will discuss in greater depth later. This 2010 paper examined the use of pre-hospital TXA administration for hemorrhage control and was one of the largest randomized control studies ever performed in the trauma literature. Another landmark trial, the WOMAN trial in 2014, looked at TXA use in postpartum hemorrhage and found that its administration reduced mortality. Today, TXA is used in multiple surgical specialties, including cardiac surgery, OBGYN, oral and maxillofacial surgery, hepatobiliary surgery, orthopedic surgery, and trauma, in addition to its continued use in bleeding disorders and epistaxis. Currently, however, the only FDA-approved indication is for hemophilia and heavy menstrual bleeding. Despite the widespread prevalence of TXA use in multiple surgical fields, technically they are all actually off-label uses at the moment. So why does TXA work? There's still a lot that we don't understand about coagulopathy and trauma, but we do know that it's a common and potentially deadly problem. Fluid and blood transfusions can contribute to coagulopathy, as can the lethal diamond, i.e. hypothermia, acidosis, coagulopathy, and hypocalcemia. We know that there is a substantial inflammatory response to trauma, particularly in IL-6 activation, which also has modulatory effects on both bleeding and clotting. Traumatic coagulopathy is very much a double-edged sword, exacerbating bleeding at initial presentation, but also increasing the risk of arterial and venous thromboembolism. Trauma patients are at highest risk of bleeding-related death within the first few hours of presentation, but the long-term cause of death is most commonly from multi-organ failure, largely thought to be caused by microvascular emboli from DIC. One of the ways that we attempt to manage both bleeding and clotting is with thromboelastography, or TEG. I have included a diagram here which shows the phases of coagulation as well as the fibrinolysis phase. The phases of coagulation include clot formation, achievement of clot firmness, and maximum strength of the clot. The fibrinolysis is measured as the LY30, or the percent of the clot that's lysed 30 minutes after it reaches maximum strength. There is a very nice study out of the University of Colorado on the dual problem posed by traumatic coagulopathy. It discusses the term hyperfibrinolysis, which they define here as an LY30 greater than 3% on TEG, and which refers to excessive clot breakdown, as well as fibrinolysis shutdown, which they define as an LY30 of 0 to 0.8% on TEG, and indicates increased risk of DVT and multiple organ failure. Their study found that while hyperfibrinolysis is the most rapidly deadly, with mortality rates over 70%, fibrinolysis shutdown was actually the most common finding in trauma patients. Both hyperfibrinolysis and fibrinolysis shutdown had significantly higher mortality than physiologic LY30 ranges, however, with multiple organ failure 40% in the shutdown group and 70% in the hyperfibrinolysis group, bleeding-related death 15% in the shutdown group and 66% in the hyperfibrinolysis group, and TBI-related death 45% in the shutdown group and 26% in the hyperfibrinolysis group, although this was not a statistically significant difference. As this study neatly encapsulates, both bleeding and clotting have high morbidity and mortality in the trauma population, so our goal has to be to balance both. We know that plasminogen and plasmin levels peak about 1 hour after traumatic injury, and plasminogen activator inhibitor levels peak approximately 3 hours after traumatic injury, at which point they inhibit fibrinolysis and can cause DIC. Because of this, TXA is theoretically most beneficial if given within 3 hours of injury, particularly within the first 60 minutes, because that would be the time frame where it functions on high levels of plasminogen to prevent accelerated fibrinolysis and clot breakdown, but won't contribute to the fibrinolysis inhibition from other plasminogen activator inhibitors and the excessive clotting that we see at 3 hours after injury. And of course, if TXA is most beneficial within the first 60 minutes, a lot of the times that administration window will actually fall within the pre-hospital phase. This study for thromboembolism. So it's possible that this was actually underreported. One of the most exciting things about this study was that they demonstrated a survival benefit with the TXA group, despite the fact that the TXA group was significantly sicker and more injured than the placebo group. This suggests, particularly in the military population, with again the higher rate of combined blunt and penetrating trauma, that if these patients can benefit from TXA, that there's a high likelihood that civilian patients will also benefit from TXA and possibly even to a greater degree. This was one of the first trials that sparked interest for ongoing investigation into TXA for hemorrhage control. The CRASH-3 trial was a multinational 2019 study. This arose because of a subgroup analysis of the CRASH-2 trial that had examined TXA use in TBI patients more carefully, which prompted this massive multinational study that had centers in Europe, Africa, Asia, South America, North America, and the Middle East, including multiple third world countries. This was one of the first papers to examine TXA use in brain injury. They collected over 12,000 patients with a GCS equal to or less than 12 who were assigned to receive 1 gram of TXA plus an additional gram of TXA versus 2 placebo doses within 3 hours of injury. They found that all-cause mortality was not statistically significant between the TXA and placebo groups, and the head injury-related death was slightly lower in the TXA group, 18.5% versus 19.8% in the placebo. Interestingly, they noted that the benefit was greater in the mild and moderate head injury groups, not the severe head injury group. They also noted that early treatment was more effective than later treatment in mild and moderate head injury. They did find that there was a similar risk of thromboembolic event and seizure between the two groups. You can see that the thromboembolic event was about the same between the TXA and placebo groups within 3 hours administration, and it was slightly higher in the placebo group compared to the TXA group if they split it out to more than 3 hours. Similarly, the seizure rate was about the same for TXA and placebo groups within 3 hours, and about the same again for TXA and placebo groups if it was administered more than 3 hours after injury. Limitations here were that they didn't do universal screening for thromboembolism, so again, it may have been underreported. But interestingly, in this paper showed that there was that the more severe the injury, the head injury, the less the patient seemed to benefit, which is kind of the opposite of what we had found in the MATTERS trial. So the thromboembolic rate, as we've discussed, is one of the big complications of TXA. We're probably, unfortunately, never going to know the true risk because there are too many variables that contribute to thromboembolic risk in trauma patients. Transfusion and resuscitation requirements, injury severity, immobilization, and operations required for traumatic injury all contribute to the high rate of VTE in this population. In addition, DVT prophylaxis is often held in trauma patients despite the increased risk of VTE, particularly in the setting of head surgery or brain and spine, head injury or brain and spine surgery. DVT prophylaxis is also often held for patients who have ongoing bleeding, despite the onset of increased microvascular clotting at only 3 hours past injury. There are multiple studies that have tried to determine the risk of thromboembolic rate in TXA use, which continues to be a problematic issue because there are multiple conflicting conclusions from different studies. I've included here 3 papers. The first, Czarnecki 2019, was a meta-analysis of 22 randomized controlled trials across different surgical specialties. These all looked at non-operative patients who received TXA, including the CRASH-2 trial. They found that the relative risk of VTE was 0.97, therefore not significantly higher compared to placebo. But of note, this meta-analysis did exclude patients who had a known history of thrombosis, which is one of the current contraindications for TXA use. Tauber 2021 was another meta-analysis of 216 trials that looked at 125,000 patients. They did find that there was a similar rate of thromboembolic event in the TXA groups versus the placebo groups, and they did include patients who had a known history of thrombosis. And their conclusions agreed with Czarnecki, even though they had a more inclusive and expansive patient population, if you can call it that, from a meta-analysis. Myers 2019, however, which was a retrospective cohort study of 189 pairs with good propensity score variable matching, they looked at people who had TXA within 3 hours for hemorrhage control versus placebo. And they found that the thrombobolic rate was significantly higher in the TXA group, 15.3% versus only 7.4% in the placebo, with an odds ratio of 3.3 for VTE. Now, a couple things to note here. They did find that patients who had TXA had less DVT prophylaxis as a whole. They had higher rates of smoking, which also increases your risk of thrombembolic event, and higher rates of penetrating injury, as well as a higher median injury severity score. So they were sicker and presumably had more blood transfusions, which again could have contributed more to thrombembolic rate. But even after they adjusted for mortality, they found that the risk of VTE remained elevated in the TXA group compared to the control. However, they did not find that the mortality was significantly different between the TXA and control groups, which is interesting because it suggests that even though they did find a higher rate of DVT and PE, it didn't seem to affect the mortality, which suggests that this may have been not necessarily the most clinically significant finding, at least not to the point where it can increase the mortality rate. Finally, the Tampede trial, which was done in the US in 2020, was a randomized control trial of 149 severely injured patients that sought to look at the DVT rate. The patients were randomized to receive 2 grams of TXA, 4 grams of TXA, or a placebo, and the median time of administration was roughly 60 minutes from the time of injury, so well within the ideal TXA administration timeframe. They drew blood before TXA administration and again at 6, 24, and 72 hours, and they examined rates of fibrinolysis and immunomodulatory effects. They found that TXA that was given to patients with active bleeding does trigger an immune response in IL-6 production. However, they found that the effect was relatively minor compared to the greater changes in immune response and hemostasis that are induced by traumatic injury. They did not find any differences in biomarkers of endothelial activation, the number of transfusions, the rate of multi-organ failure, or the mortality between the two groups. They did find a statistically significant increase in thromboembolic events in the TXA groups versus placebo, 26.5% in the 2-gram TXA group, 32% in the 4-gram TXA group, and only 12% in the placebo group. The limitations were that, again, not all patients were screened for DVT, so the thromboembolic may actually have been underreported. In conclusion, they did find that there was a significant increase in thromboembolic events in the TXA groups, and particularly with the 4-gram dosing, the higher dosing compared to the 2-gram group. But again, there was no significant difference in the rate of multi-organ failure or mortality, which suggests that even though there probably is higher rate of DVT, again, it may not be clinically significant. So now that we've reviewed the background, hopefully provide some context for the questions that we are still trying to answer about TXA use in trauma. First, where should it be given? We've talked about the theoretical best window for TXA administration and how it may often land in the pre-hospital setting, but should we also be giving it in hospital? When should we be giving it? Does it matter if we give it outside the theoretical best window of 3 hours, or is it better to give it late or not, rather than not at all? How much should be given? Keep in mind that, as we discussed earlier, TXA is a reversible and competitive inhibitor of plasminogen, so giving a low dose may not be efficacious, and giving a single dose may not result in long-term hemostasis. We're still trying to determine both what dose of TXA needs to be given, as well as how often it needs to be redosed, if it needs to be redosed at all. Should everyone get it? There is a very wide range of traumatic injury, even at the level traumas. Some go home, some get admitted to the floor, some go to the ICU, and some never make it out of the trauma bay. Obviously, the degree of bleeding between these different patients can vary dramatically. Trauma can also happen to every part of the body, and an isolated head injury patient is very different from a GSW to abdomen. Do all these people benefit equally from TXA? Finally, what is the true risk of adverse effects? We've discussed thromboembolism and seizure as the main risks, as well as how there is a ton of conflicting data on the actual incidence of these risks, particularly with thromboembolic rate. But again, there's a wide range of trauma patients and injury severity, and the risk for a less injured population may not be the same as the risk for a severely injured population. To answer these questions, let's start by looking at the trials done for hemorrhage control. So the CRASH-2 trial, which was done in the UK in 2013, was a randomized control trial This enrolled over 20,000 patients who were randomized to receive either 1 gram of TXA loading dose in the pre-hospital setting, followed by an additional 1 gram of TXA maintenance dose versus 2 placebo doses. The findings were that there was an absolute mortality reduction of 1.5% and the relative risk reduction of 9%. The 28-day mortality was 14.5% in the TXA group, slightly lower than the 16% in the placebo group. They did find that bleeding-related death was reduced when TXA was given within 3 hours of initial injury, but it increased if given more than 3 hours after initial injury. They further split it up by time frame. So the TXA given within 1 hour of injury had a 5.3% mortality versus the 7.7% mortality in the placebo group. TXA given within 1 to 3 hours after injury had a 4.8% mortality versus 6.1% mortality in the placebo group. TXA given more than 3 hours after injury had a 4.4 mortality in the TXA group, and actually there was a decrease in mortality, only 3.1% in the placebo group. They did not find any significant difference in bleeding, the number of blood transfusions required, or the vascular occlusive events between groups. Limitations of this study included that they had an overall low injury severity score and a low rate of penetrating trauma. So with low penetrating trauma and low injury severity score, this may not be applicable to all trauma patients. And also patients may have had reduced transfusion requirements at baseline, which also could have confounded the perceived benefit of TXA as well as the thromboembolic event rate. Presumably, this patient population would have had a slightly lower thromboembolic risk and also less severe trauma coagulopathy. However, the sheer number of patients enrolled pretty strongly suggests that TXA given within 1 hour and within 1 to 3 hours after injury reduces mortality. Although, again, of note, more than 3 hours after injury, TXA seemed to increase mortality compared to placebo. The other big trial for TXA use in trauma hemorrhage is the STAMP trial, which was done in the US in 2020. This was a randomized control trial of 903 patients stratified into a placebo group, patients who got 1 gram TXA pre-hospital, patients who got 1 gram pre-hospital, an additional bolus for a total of 2 grams, or 1 gram pre-hospital, an additional bolus, and a 1 gram maintenance dose for a total of 3 grams. They found that the pre-hospital 1 gram group did not have significantly lower 30-day mortality compared to placebo. However, they did a further subgroup analysis and they demonstrated a 10% mortality in the placebo group, 9.3% in the 1 gram group, 7.8% in the 2 gram group, and 7.3% in the 3 gram group. So obviously lower mortality with higher doses of TXA. They did also find that TXA reduced mortality if given within 1 hour of injury, 4.6% versus 7.6% mortality in the placebo group. And it also had a lower incidence of multiple organ failure and transfusion requirements compared to placebo if given within 1 hour of injury. It also reduced mortality in patients who had severe hemorrhagic shock, which they defined as a systolic blood pressure of equal to or less than 70 millimeters mercury, 18.5% versus 35.5% in the placebo group, which is a significant difference. They did not find that there was a difference in the thromboembolic rate between the TXA groups and the placebo group. Limitations of the study were, again, like the CRASH-2 trial, that there was a relatively low injury severity score and blood transfusion requirement, and this study was actually underpowered. They did demonstrate here a benefit in the 2 gram and 3 gram groups, and of note, the 2 gram group had the 1 gram plus 1 gram dosing that was taken from the CRASH-2 trial. So overall, I would say that the study is in consensus with the findings of the CRASH-2 trial. And it also supports the findings of the MATTERS trial because you see significant benefit in patients who have severe hemorrhagic shock. Other studies for TXA use in hemorrhage. Al-Mobilad 2021 was a meta-analysis of 4 studies that looked at TXA use in hemorrhage. They found that pre-hospital TXA had a 40% reduction in 24-hour mortality compared to no TXA. They also found that pre-hospital TXA reduced late mortality, which they defined at 28 to 30 days here, but it was not statistically significant compared to placebo. And they also found that pre-hospital TXA increased the VTE rate, but it was not statistically significant. Finally, Stansfield et al. 2020 was a meta-analysis of 14 articles that looked at TXA and hemorrhage. They found that the 1 gram plus 1 gram dose, aka the CRASH-2 dosing, had the best outcomes, and that the TXA group tend to require more PRVCs and total fluid, so was probably sicker than the placebo. Limitation of this study were that patients likely received more than 1 liter of crystalloid, which does worsen coagulopathy. So in other words, Stansfield et al. Concluded that the 1 gram met the minimum goal of achieving a minimum concentration of 20 mics per ml of TXA, and that giving an additional infusion over 8 hours ensured therapeutic levels of TXA over a longer time frame. The authors also agree with the optimal window within 3 hours of injury that we found in CRASH 2 and also STAMP, and ideally within 1 hour, and overall agree that TXA is safe to give in the pre-hospital environment. So now that we've gone over those trials, we can start to answer some of these questions. Where should TXA be given? Ideally in the pre-hospital setting, because that's the first opportunity to administer TXA. And as Al-Mulawad showed, there is a significant benefit and mortality reduction if you can give it in the pre-hospital setting within 1 hour. When should it be given? As it turns out, the biochemistry is a perfect predictor of outcome, with best results within 1 hour as plasminogen and plasma levels peak, as demonstrated by STAMP. But mortality increases after 3 hours as demonstrated by CRASH 2, which is consistent with elevated plasminogen activator inhibitor levels and increased clotting. How much should we be giving? The MATTERS dosing was 1 gram without a second dose. The CRASH 2 dosing was 1 gram pre-hospital followed by 1 gram of maintenance, which was superior to placebo. And STAMP compared that dosing to 1 gram pre-hospital plus 1 gram bolus plus 1 gram maintenance for a total of 3 grams and found approximately the same mortality rate. STAMP also demonstrated that repeated doses had lower mortality than single dosing. While this is not a definitive conclusion, I would say at this point that the literature supports the CRASH 2 dosing regimen, plus minus an additional 1 gram maintenance dose as seen in STAMP to decrease mortality. Though it is interesting that the single 1 gram dose that had survival benefit in MATTERS was not replicated in the findings of either CRASH 2 or STAMP, despite the fact that the MATTERS population was significantly sicker than the CRASH 2 or STAMP population. Should everyone get it? Yes. MATTERS and STAMP both demonstrate that there was particular benefit to severely hypotensive patients who received TXA. Both STAMP and CRASH 2 had relatively low injury severity scores, but also demonstrated benefit. So we've seen the TXA improve survival in both the very injured and the moderately injured patient populations. I would argue, therefore, that every patient with significant risk of bleeding should receive TXA. Finally, what is the true risk of thromboembolic events? Though neither CRASH 2 nor STAMP found higher thromboembolic rates, MATTERS, TMP, and Myers 2019 all found significantly elevated thromboembolic rates. That being said, however, none of these studies found increased mortality in the TXA groups, which suggests that even if a patient had a thromboembolic event, it was likely not that clinically significant. Overall, TXA does seem to be a safe drug, even though it does likely somewhat increase your risk of thromboembolic event. And ultimately, a DVT and a PE can usually be survived, but it's kind of a moot point if you've already bled to death. Now that we've addressed our questions for TXA use in hemorrhage control, let's move on to examine it in traumatic brain injury. The first trial I want to talk about is the pre-hospital TXA for TBI trial, which was a US and Canadian study in 2020. This is a randomized controlled trial, 900 patients with TBI and systolic blood pressure equal to or less than 90 millimeters of mercury. Patients were stratified to receive 1 gram TXA pre-hospital plus a 1 gram bolus, 2 grams pre-hospital, or a placebo, and the TXA was all given within 2 hours of injury here. While there was no significant difference in overall mortality or 6-month functional outcome between the TXA groups and the placebo group, there was improvement in mortality and 6-month functional outcome in patients who had confirmed intracranial hemorrhage and received 2 grams TXA. There was also a small and uncertain improvement in functional outcomes noted in patients with moderate and severe TBI who had received TXA. The 28-day mortality was lower in the TXA groups, but the overall mortality was not. In addition, the authors concluded that the 2 gram dose does not have significantly different rate of adverse events and has survival benefit compared to 1 gram plus 1 gram and placebo. So they recommended a 2 gram group, especially for confirmed intracranial hemorrhage. Limitations of this study were that there was, again, a lower injury severity score, and patients did tend to have a higher GCS. So these patients may not have been terribly injured, and the study also may have been underpowered. The association between pre-hospital TXA administration and outcomes of severe TBI was a large trial out of the Netherlands in 2021. This was actually a subgroup analysis of the Brain Protect study, which had been a large prospective observational study that examined pre-hospital management of patients with severe TBI. The subgroup analysis ended up including about 1,800 patients, all of whom received either 1 gram or 2 grams of TXA pre-hospital. Of note, if they did receive further dosing, it was not reported in the study. Their findings were that the pre-hospital TXA group had a significantly higher 30-day mortality, 37% versus 30% placebo. However, they did not have increased mortality after they adjusted for possible confounding variables. They did find that the 12-month mortality was consistently higher in isolated severe TBI patients who had received pre-hospital TXA compared to the placebo. They did not find that the 2-gram TXA dose had significant increase in adverse effects over the 1-gram dose. Limitations of this study were that there was inconsistent pre-hospital TXA dosing with the 1 gram versus the 2 grams. And also this was a subgroup analysis, so by definition, lacked some of the granularity of a randomized control or prospective or retrospective study. The results of the study are also complicated by the fact that additional bolus dosing of TXA in hospital was not reported, but the findings suggest that patients with severe TBI, which they defined here as a GCS of equal to or less than 8, do not benefit from TXA. Like the pre-hospital TXA for TBI trial, they did not find a significantly different rate of adverse events with the 2-gram dosing. Finally, this study, the effects of timing of pre-hospital TXA on outcomes after TBI, was a subgroup analysis of the pre-hospital TXA for TBI trial. They enrolled about 650 patients who had either blunt or penetrating trauma, as well as a suspected TBI. Patients received either 2 grams of TXA or 1 gram TXA plus 1 gram maintenance dose. So again, the CRASH 2 dosing. All patients received either pre-hospital TXA either within 45 minutes of injury or between 45 minutes and 2 hours of injury. Their findings were that there was no mortality benefit in moderate or severe TBI if TXA was given within 45 minutes versus within 2 hours of injury. The thromboembolic and vasospasm rates were lower if patient received TXA within 45 minutes. There was no mortality benefit found with a very early TXA administration, aka within 45 minutes, in TBI patients unless they were also in shock. The thromboembolic and vasospasm rates were found to be higher in the 2-gram group. The higher dose TXA bolus with or without maintenance did improve outcome compared to the lower dose bolus with maintenance. Limitations were, again, that this was a subgroup analysis, and also the accuracy of timing windows was a little bit suspect. Obviously, they tried very hard to get everyone TXA within 45 minutes or within 45 minutes to 2 hours. However, given that this was a very short time frame, it's hard to know if everyone actually received TXA within the appropriate time frame that they thought they did. The results of the study were also complicated by the the authors concluded that there's no mortality benefit for TBI patients unless they're also in shock, and also that higher TXA boluses with or without maintenance infusion had improved outcomes compared to lower doses, i.e. the 1 gram plus 1 gram regimen. There was also another study by the same group that examined 967 patients who received 2 grams, 1 gram plus 1 gram, or a placebo in patients with suspected TBI. And they found that the 28-day mortality was the same for patients treated with 2 grams of pre-hospital TXA and 1 gram plus 1 gram of TXA, but that mortality was reduced in patients with confirmed intracranial hemorrhage who had received 2 grams of TXA pre-hospital compared to placebo, which again is consistent with both the pre-hospital TXA for TBI trial and the Dutch study. So to address our questions again for TBI, where should it be given? Biochemical analysis has shown that TBI has less hyperfibrinolysis than hemorrhagic shock, and therefore there may be a narrower window for ideal administration. Most of these studies gave TXA within 2 hours, and the subgroup analysis of the pre-hospital TXA for TBI trial demonstrated fewer adverse effects if TXA was given within 45 minutes of injury. In my opinion, I think that the ideal window for administration for, hold on, let's try that again. Sorry guys, bear with me for 1 second. Okay, All right. As I was saying, in my opinion, I think the ideal window for administration is within 45 minutes, but not more than.
Hello?
Yes.
We're not sharing slides right now.
Oh, okay. Let me try that again then. Okay. Tom, can you see it now?
Yes, and I think we were on slide 21 or 22.
Yes, here we are. Okay, sorry about that. So again, in my opinion, I think that the ideal window for administration for TBI is within 45 minutes, but not more than 2 hours after injury. How much should be given? Most of these studies demonstrated a greater benefit with 2 grams. The pre-hospital TXA for TBI trial was the only one that found a higher rate of DVT-PE and seizure in the TXA group, but his overall mortality was not different, and the 2-gram group actually had lower mortality. Like with the hemorrhagic data, I would suggest that the 2-gram group probably is safe and had better mortality benefit, despite the fact that there was increased rate of vasospasm and thromboembolic event, which may not be clinically significant. Should everyone get it? Here, I think there is a substantial difference from the TXA for hemorrhage data. CRASH 3 demonstrated that there is no benefit from TXA in severe head injury, and the Dutch trial demonstrated actually worse outcomes if TXA was given for severe isolated TBI. Additionally, the pre-hospital TXA for TBI trial subgroup analysis showed that there was no benefit from TXA administration unless the patient is also in shock. The best indication for TXA administration seemed to be in patients who had known intracranial hemorrhage, but unfortunately that diagnosis may or may not be made within the ideal 2-hour administration window. I would say that certainly any patient with potential head injury and shock should receive TXA, as should patients who have obvious mild or moderate head injury. I think the data shows fairly convincingly that patients with severe isolated TBI probably do not really benefit from TXA administration. Finally, what is the true risk of thromboembolic events, seizure, and vasospasm in this population? Again, I don't think we'll ever be able to truly know the incidence, but based on review of these studies, I think the DVT-PE rate is likely somewhere between 1 to 10%, seizure probably around 5%, and vasospasm 1 to 2%. While all of these events complicate treatment, like the need for full anticoagulation in patients with known intracranial hemorrhage if they have a DVT or PE, or it increases the risk of secondary brain injury, such as seizure or vasospasm, which can reduce long-term functional outcomes. Ultimately, none of these events seem to really affect mortality rates, and I would suggest that TXA is overall quite safe in TBI use. Current guidelines for TXA use. Well, there really aren't any. The Committee on Tactical Combat Casualty Care 2022 guidelines recommend administering TXA 2 grams if a patient will likely need a blood transfusion or has signs or symptoms of significant TBI. They don't define what significant means in terms of GCS. There are guidelines pending from the Eastern Association for the Surgery of Trauma and the Western Trauma Association. There are currently no guidelines for the Brain Trauma Foundation or the AAST. Challenges to pre-hospital TXA administration. So of course, even though we've established that it's certainly possible and probably ideal to give TXA in the pre-hospital setting, there are certainly still barriers to universal application. This was a study that interviewed 18 UK paramedics and asked about their experiences administering TXA pre-hospital. The barriers that were identified from these interviews were first that paramedics sometimes had difficulty identifying patients who were at risk of bleeding after trauma, and some participants were unsure about who would benefit from TXA administration. TXA was seen as only indicated for major trauma, according to the reports, and participants sometimes worried about being judged negatively by colleagues for liberal administration of TXA. TXA was often not seen as a priority in resuscitation compared to giving IV fluids or blood. And additionally, participants often cited a lack of time and available hands for administration, particularly if there was a 2-person crew. Some participants were unsure about the safety of TXA, but most of them reported that they felt the benefits outweighed the risks. And I hope that at the end of this talk, some of our EMS providers will give us their thoughts on the barriers they've experienced with TXA administration. So to conclude, the best practice for TXA administration is not entirely clear, even though there have been many trials about this. It is likely not the same for hemorrhagic shock and traumatic brain injury, which also complicates our ability to define what we should be giving to patients. In addition, identifying which patients would benefit from TXA can be difficult, as not all bleeding is immediately apparent. There are, however, some common themes in TXA administration. First, the earlier you can give it, the greater the benefit, and we do know that we should be giving it within 3 hours of injury, and probably not after that window unless there is evidence of hyperfibrinolysis on in-hospital TEG. Second, we know that TXA administration may, and in fact probably does, increase the risk of thromboembolic events, that the risk is low, certainly not more than 10% and probably less than 5%, and it's probably not clinically significant enough to increase mortality. In conclusion, I would say that if you were unsure about whether a patient would benefit from TXA, I would default to giving it as long as you are within that 3-hour window. And I would also suggest giving the 1 gram plus 1 gram maintenance dose for hemorrhage, and potentially considering giving a 2 gram bolus up front for isolated head injury. Here are my references. And just again, a summary of the different, I think, indications for TXA in hemorrhage and TBI use. Thank you very much. I'm happy to take any questions.
Dr. Edwards?
Yes, I'm so proud to have Dr. Anna Wu as part of the team. She's grown up to be such a great ACS surgeon, and I'm so happy about this talk. What I want to give to you, Dr. Wu, on this is that the issue is one. I had a lot of questions, and the first one is, I can't believe that published study with 18 paramedics interviewed. We have more than 18 paramedics, I'm sure, on the line right now. I mean, we can do that study to say what are the barriers to administering. So I do want, as you encourage the people out there, our people on the pre-hospital. This talk was from us in the hospital to you on the pre-hospital. I wanted to try to give you some clarity on what we're thinking, but mostly because, as Dr. Wu's highlighted, if you give it, and you know, your EMS director has said, hey, you've got TXA out there, we want to follow up by administering the 2nd gram. And I am seeing a variability out there. I think that you did an excellent job in reviewing the literature. I think that you highlighted some barriers, and even though it was only 18 paramedics, I do think that's one of the reasons we're having this talk, is to try to say, hey, what are your barriers? What are you thinking? Do you need more information? And it's the TBI and the shock. I mean, what I got from you, Dr. Wu, and you can clarify this, if you come to the scene and it's a bloody mess, the person's hypotensive, you should think about giving TXA. Because that seems to be where we're going to find the benefit in the early pre-hospital. Is that right?
Yes, I would agree, absolutely. I would say that just like in the in-hospital setting where we prioritize hemorrhage control over management of TBI, if there is a combined TBI and hemorrhage control issue, I would say that same thing with TXA. The first priority has to be to save somebody's life by stopping them from bleeding to death. So even if you're not sure whether they would benefit from TXA for TBI indications, if there's also hemorrhage present, just give it.
Good. And then how about pre-hospital, Mike Daly or somebody out there? How many people are carrying TXA? How many people are administering it? What are y'all thoughts on the TXA?
And barriers to administration.
Give it. I get it.
We have one comment in the chat said it's new.
So I'm gonna jump in. I of course was the guy who couldn't get off mute. I apologize. First of all, Dr. Wu, welcome back to Albany.
Thank you.
I'm really excited to have you back, and I think you were fantastic when you were here the first time, and going out and working with Dr. Gestring and coming back here. This is extremely exciting addition to our trauma service. The background in this talk is really important. It clearly demonstrates that there's benefit from early administration of TXA, and early administration means EMS. So what I had asked in the chat, and thank you to Jamie for answering up, was to really follow Dr. Edwards' question. What is it that's causing barriers to TXA administration for patients in hemorrhagic shock in our region? That's an important question for us to ask and ultimately to answer at the level of the service. I think you've put out the mandate to folks. If there's a person in shock after a traumatic injury, they should get TXA. Pre-hospitally, they're going to get a gram. And we'll follow that up in the hospital if it's already been done. So please, Jamie, thanks for starting us out. Steve, I know you're on as well, but I'd really love to hear from some of the EMS providers out there so we can start to do this important intervention.
So we got one comment says we are carrying it, but no administrations yet. Second one, scene to hospital time, short transfer times from scene to local hospital with a critical patient. And the third comment is, I think providers have a misunderstanding that it is going to cause excess clot formation. And Dr. Cordy said we carry it.
So I think the important thing to take from there was Dr. Wu's most eloquent comment that a DVT is a moot point if you've already bled to death. That was an extremely important point to make.
Dr. Daly, it's Jamie. Can we go the other way with this? Like when we give a trauma alert to Albany Med, can the trauma doc say, is this hemorrhagic in nature and did you consider TXA? Sometimes it's better if it comes from the other side.
I think that makes a lot of sense. And Jamie, we'll push that out to the residents that are going to do the remo calls. That if you're bringing somebody in that sounds as though they're in hemorrhagic shock, to push that information back up the line. Great advice.
Yep.
Another comment, if admin, should patient only go to a level 1 trauma or is it okay to go to a lesser facility?
I think that it shouldn't really matter, in my opinion. Perhaps Dr. Daly or Dr. Cordy or Dr. Edwards have some thoughts on this, but I think the whole point of TXA is that it helps you stabilize patients, and it tries to rescue people during that golden hour of trauma surgery where we have the highest mortality from bleeding. So, ideally, you should give it to anyone, and then I don't think they necessarily have to come here. Hopefully the TXA administration helps stabilize them so that they can be safely transported to the next phase or, the first available hospital that can take care of them.
Great comments, Dr. Wu, and frankly, I think that's true. But at the same time, the complexities of secondary transfer of a sick trauma patient are real. So most of these patients within this region should be transported directly to the level 1 center rather than have a stop in between. If you're north of Glens Falls or well southeast of Columbia Memorial or west of Amsterdam, then it becomes a real question as to whether you're better off to stop for blood as well on the way to ultimately your final destination, because these patients need the resources that are only available here.
Yeah, my question is for people out there. I've seen, and I know that most of the paramedics are wanting to use the chat, and I'm happy with that. Who does not have it? As somebody says an EMS, like, we don't have it, I haven't heard about it. That's important to me also, to know, hey, how pervasive is it? Because it's not like, and Mike, you can correct me, it's not a mandate from the state or anything that you have TXA. That's local directors, isn't that correct?
It was not a mandate addition to the formulary initially, which is the way we always bring on new interventions.
So another comment here from the chat box, reviewing the protocol, why not give TXA if patient is still entrapped?
So the reason we wrote that is because if the patient is still entrapped, it is very rare for that patient to be getting IV access because the initial priority is going to be getting that patient out of the entrapment. situation. So what we did is we wanted to make sure that we weren't giving people conflicting priorities that might ultimately create more potential hazard for that patient.
It appears North Country does not have TXA on rigs.
Good. Tammy, thanks for that.
And I'll just throw in, I'm going to share the information to get your CME. We can still ask questions here. I'm just going to put it up.
Yeah, I had a quick question, if you can hear me. This is Caleb from one of the residents. I didn't know if they had sussed out any of the groups for like either excluding them from these studies or including them in the thromboembolic risk, but patients that are needing reversal of their anticoagulation who have traumatic injuries and would otherwise be a candidate for TXA. I didn't know if they looked at that subgroup at all.
I can tell you that certainly the subgroup analyses did not. So are you talking about mostly the TBI papers, I assume?
I don't know. You can address it all. It's a great question. Did they
Sure.
people who are on anticoagulation,
Mm-hmm.
rather from hemorrhagic shock or a TBI,
Mm-hmm.
do they account for those people on anticoagulation? I think that based on the biochemistry, we're talking about fibrinolysis and the anticoagulation that people would be on warfarin or DOACs or on there.
Mm-hmm.
It could be a different part of the cycle, but it's a fantastic question to say,
Yeah.
did anybody look at somebody who's on anticoagulation prior to their trauma?
Mm-hmm. Yeah, I think I have to go back again and look at the Tampede trial, which was, I think, probably the one that would have been most likely to do that. Off the top of my head, I don't think that any of the other trials looked specifically at patients who required reversal, which is a very good question. And again, I think the problem is that with TXA, we know that patients have a tendency towards both fibrinolysis shutdown and hyperfibrinolysis, but you don't know which one you're looking at when a patient comes in. Again, I think that we feel that when patients come in, they have a tendency towards hyperfibrinolysis if they're sick, but actually the fibrinolysis shutdown is the more common finding in this patient population. So it's a little bit of a moving target, but I'll go back and see if Tampede did anything because they looked at the mechanics of it most carefully and I think they probably would have been the most likely to consider if patients had reversal. But yeah, that's an excellent question, Caleb.
We've got a comment from the field. Not long ago, tourniquets were taboo. Now there are public access tourniquets. Awareness and easy access to training will increase use.
Is what Dr. Wu is doing, increasing education and then that's why I want to know about access. It sounds like there's pretty good access out there for the EMS other than like North Country. So that's good.
Hey, Dr. Edwards, it's Carrie. And Art, Art on? Art is on. Art, would this be a benefit to bring to the EMS conferences that you have online?
Absolutely, sure. And I was going to ask Tom for this. I was going to kind of get the video afterwards and then send it out.
Okay.
You're gonna live, Dr. Wu. You're gonna live out there, in the EMS world for your lectures.
That'll be
Dr.
my
Edwards
internet
and
presence.
Dr. Edwards and Dr. Wu. This is Jared from ACS or AMC Trauma Quality. So on the in-hospital side of things, we are finding an increased rate of patients on DVT prophylaxis or VTE prophylaxis that are still having PEs and DVTs. Do you think this would be a good educational point for the hospital providers that if the patient had received TXA, that it might increase their index of suspicion if the patient's having increasing swelling in the limb or increasing oxygen demands or tachypnea, that maybe they should receive a CTA of the chest or something like that for possible PEs?
Yeah, I absolutely agree. Again, it's so hard to know, and especially because there's so many confounding variables, but my strong feeling is that there probably is an increased risk of thromboembolic event. We just don't know what it is. It's probably not high, and it doesn't seem to affect mortality in any of the studies we've looked at, but it probably is there. So, again, is anyone who has DVT prophylaxis that's being held, anyone who had a tag that was concerning for fibrinolysis shutdown, I think those people especially, we should have a very high suspicion for a DVT or a PE. But, again, ultimately, I think these people, the question is, should we screen everyone for it? And I don't think we should. We'll always find things, but it doesn't, my feeling is that it's probably not that clinically significant. We found a couple of DVTs and PEs in the last month or so on the trauma service, and these patients showed us signs of it, but none of them were actually that sick. They all seem to compensate pretty well for that. So it was, of course, something that we wanted to identify and address, but I don't think that it would have changed their trajectory for what it's worth.
Yeah, I mean, Dr. Wu's statement is that as you all, and the reason I wanted this too is that we on the hospital side are going to have to look at our practice. As you all out there in the region start using TXA, and I saw people out there, they're starting to come on board with it. They haven't used it. It's available. As that process gets more and more, because that's what I wanted a feeling for, that you're all using it, we in the hospital are going to be, and we're right now in the process of trying to do the point of care tag with the cartridge. I believe it's on us to go back to Jared's question to say, you come in and you administer tag, and Dr. Wu's presented a nice Colorado study by Moore. There's some people who are in fibrinolysis shutdown, and it's on us to do the tag when the person comes in and to say, oh, no, we probably don't need to put another gram on this one because they're in fibrinolysis shutdown. Oh, they're in shutdown. We need to be more sensitive about the BTE complication that can go down. I think that's the process where we're needing to go forward, because the first step is to say it seems very safe, and as long as it's administered early, the benefit is, for hemorrhage seems to be pretty solid. Maybe it's not huge as people have always argued. Two is that we can be more particular. Following up with the second gram is just a blanket statement, but I think as we go forward, based on what you all are doing in the pre-hospital, we should probably be saying these are the people we should get a tag on and look for that shutdown, which is what they did in Colorado. And that will be a little more judicious. But I think right here, you all need to walk away and say it seems safe, and it possibly is a benefit for those hemorrhagic shock patients out there. And I like the statement that somebody made, said, hey, can you ask us, should we give TXA when we're talking about a hemorrhagic shock?
Yeah, absolutely. And again, even though fibrinolysis shutdown is more common, the early mortality is still from hyperfibrinolysis. Absolutely. The late mortality is from shutdown, and that's the multi-organ failure, but the bleeding to death is still it's still the first problem that we have to address, and it's still the first priority. So.
All right, so if I can interject for just a second here, for those physicians and APPs that are looking to claim CME credit using the Cloud CME system, the activity ID is 12328 for our pre-hospital folks looking for EMS CME. Please put your full name, certification, your number, and an email address in the chat box. And to be awarded nursing CEU, please put your full name, credentials, and email address in the chat box. I will leave this up for a few minutes after the presentation. So, if you haven't already done so, so you can take advantage of it. And I'll go on mute again if there are any other questions.
Great job, Dr. Wu. Great job.
Thank you, Dr. Wu. That was perfect. Exactly what we needed.
Thank you, everyone. Have a nice rest of your day.
You too.
There's no further questions. Thank you all for attending. For our pre-hospital folks, if anybody has any ideas for topics you'd like discussed at Regional Trauma Conference, please drop them in the chat box, and we'll look to get some speakers to address those issues from the field. Thanks again. Have a great day. Like I said, I'll leave the chat box open for another couple of minutes. Bye.